Positioning Lesson 10 covers thoracic and lumbar spine, the largest bones of the axial skeleton. These are high-density structures requiring specific technique adaptations, and the oblique lumbar view contains one of the most memorable anatomy mnemonics on the ARRT. 13 minutes. AP thoracic spine. Patient supine, true AP, mid-sagittal plane perpendicular. Knees flexed. This flattens the lumbar lordosis and reduces the OID of the upper thoracic vertebrae. CR, perpendicular to T7 at the level of the inferior angle of the scapulae. KVP, 70 piet to 80 piet. Ishi, 40 inches. Grid required. The anode heel effect is actively used here. The thoracic spine is not uniform in density. T1 through T4 at the top is thinner and less dense than T9 through T12 at the bottom. To achieve uniform exposure throughout, position the cathode, the higher intensity side, toward the shoulders, and the anode, the lower intensity side, toward the diaphragm. This compensates for the density gradient and produces a more evenly exposed image. Lateral thoracic. Patient lateral recumbent, true lateral. Knees flexed, pillow between knees to maintain position. Arms raised above the head. Prevents the shoulder from superimposing the upper thoracic vertebrae. CR, perpendicular to T7. KVP, 80 to 90, high, because the beam must penetrate through the lateral arm and lung tissue to reach the spine. Breathing technique. Long exposure time, 4 to 8 seconds, during quiet, shallow breathing. This blurs the overlying rib shadows while the stationary spine remains sharp. Alternatively, suspend respiration at end expiration. AP lumbar. Patient supine, knees flexed. CR, perpendicular to L3, midpoint between the ASTS and the xiphoid. KVP, 70 piet to 80 piet. Ishi, 40 inches. Grid required. Must include T12 through the L5, S1 junction. Lateral lumbar. Patient lateral, knees flexed. A pad under the waist if needed to keep the spine horizontal and the iliac crest level. CR, perpendicular to L3, L4 at the iliac crest level. KVP, 85 to 95. This is the thickest part of the lumbar spine. Must include T12, L1 junction through L5, S1. L5, S1 spot lateral. A specialized lateral specifically for the L5, S1 junction. KVP, 90 to 100. CR, angled 5 degrees caudal to align with the L5, S1 disc space. The thickest area of the lumbar spine requires maximum penetration. Oblique lumbar, the Scotty dog view. 45-degree posterior oblique. Right posterior oblique, RPO, demonstrates the right zygapophyseal joints. Left posterior oblique, LPO, demonstrates the left. CR, perpendicular to L3. The oblique view produces the Scotty dog silhouette from the vertebral anatomy. Scotty dog anatomy. Nose, transverse process. Ear, superior articular process. Eye pedicle. Neck, pars interarticularis. Body, lamina. Front leg, inferior articular process. Spondylolysis, a stress fracture of the pars interarticularis, the Scotty dog's neck, appears as a lucency through the neck, like a collar on the dog. This is one of the most directly tested oblique spine findings on the ARRT. Scoliosis full spine series. Patient standing upright. IR, 14 by 36 inches, 35 by 90 centimeters. Entire spine on one image. PA projection, not AP. The PA is preferred because it places the breast tissue on the exit side of the beam, dramatically reducing breast dose. Since scoliosis patients are typically adolescent females receiving serial examinations over years, the cumulative breast dose reduction from PA technique is clinically significant. KVP, 80 to 90. Ishi, 72 inches. The Cobb angle, the standard measurement of scoliosis severity, the angle between lines drawn along the end vertebrae of the curve. AP Sacrum. Patient supine. CR, 15 degrees cephalic. This opens the sacral foramina by aligning the beam parallel to the naturally anteriorly angled sacral segments. Center, 2 inches superior to the pubic symphysis. KVP, 70 to 80. AP Coccyx. Patient supine. CR, 10 degrees caudal. The coccyx points anteriorly, so a caudal angle aligns the beam along its length. Center, 2 inches superior to symphysis. Lateral sacrum and coccyx. CR perpendicular at ASIS level. For clinical concepts, myelography. Water-soluble iodinated contrast injected intrathecally into the subarachnoid space by the physician. Never oil-based contrast, never barium. Water-soluble contrast is absorbed safely. Post-procedure, head elevated 30 degrees for 4 to 8 hours to prevent contrast ascending to the brain. Demonstrates spinal cord, nerve roots, disc herniations, and cord compression. Discography. Contrast injected directly into the intervertebral disc under fluoroscopy. Reproduces concordant pain, diagnostic for the symptomatic level. Normal. Contrast stays within the disc nucleus. Abnormal. Contrast escapes through an annular tear. Common lumbar pathology. Spondylolysis, stress fracture of the pars, Scotty dog collar. Spondylolisthesis, anterior slippage of one vertebral body on the next, graded I through 4. Most common levels, L4, L5, and L5, S1. Thoracic technique challenge. The upper thoracic is substantially less dense than the lower thoracic. Without compensation, upper segments are overexposed and lower are underexposed. The anode heel effect, cathode toward shoulders, is the technical solution. This is tested directly on the ARRT. 3 thoracic and lumbar spine questions. The answer is B, spondylolysis, fracture through the pars interarticularis. The Scotty dog's neck represents the pars interarticularis. A lucency through the neck, like a collar on the dog, is spondylolysis. This is one of the most directly tested oblique spine findings on the registry. Bilateral spondylolysis can lead to spondylolisthesis. The answer is B. The 15-degree cephalic angle aligns the beam parallel to the sacral foramina and opens them. The sacrum curves anteriorly and its foramina are angled. A perpendicular CR would project them obliquely. They appear closed and poorly defined. The 15-degree cephalic compensates for this angulation. The coccyx uses a 10-degree caudal angle for the same anatomical reason. The answer is B. PA projection significantly reduces breast radiation dose. In PA, the beam enters from behind and exits anteriorly. The breast is on the exit side where dose is dramatically lower. In AP, the beam directly irradiates the anterior breast tissue. For adolescent females receiving serial scoliosis exams over years, the cumulative breast dose difference between AP and PA is clinically significant. Lesson 10 complete. AP and lateral thoracic with anode heel effect technique. AP and lateral lumbar. L5, S1 spot lateral, oblique lumbar with the complete Scotty dog anatomy and spondylolysis sign. Scoliosis PA, full spine with breast dose rationale. Sacrum 15-degree cephalic and coccyx 10-degree caudal. And myelography procedure.